Now I would like to invite Dr. Sujata Das. Dr. Sujata Das is head of the cornea at the L. Prasada Institute, Bhubaneswar, and she is a wonderful cornea surgeon, a terrific clinician, and a very good researcher, has loads of publications. Let's listen to her journey in the field of cornea. Dr. Sujata Das, please.
Good afternoon. Thanks, Rajesh, for the introduction. I'll be speaking mostly the journey of iBank, which I have spent 20 years almost. Most of my ophthalmology journey started with iBank. So this was my topic for the Oration Care Dutta Award. So the dream is to achieve zero corneal blindness in India. So I like to tell this quote: the future belongs to those who believe in the beauty of their dreams. So all of us know the prevention is the best way to control any disease, not only corneal blindness. So once cornea loses its transparency, we need corneal transplantation. However, again, we know what is the limiting factors because shortage of donor cornea. So we need lot of transplantable donor cornea in order to reduce corneal blindness worldwide. You can see out of 2.2 billion people who are blind, at least 1 million, around 50% could have been prevented by taking preventive measures. If you see this graph, Southeast Asia has more than 50%, it's the largest proportion which could have been prevented. And globally, around 50% cornea blindness is from Southeast Asia and Western Pacific. This is an economic burden because we spend a lot of money in treating the disease at the late stage and lost earning not only to the person, also caregiver, finally leading to lower quality of life, social, economic, and health cultural term. So the annual cost of potential productivity loss cost around $410 billion. So out of 37 billion worldwide, blind worldwide, 17 million can be cured by cataract surgery, and which is very success rate, 90-80%. So it's not only restricted to one country or any age. So socioeconomic status, anybody can get affected. So if you see this NPCP data, corneal opacity is second if you see age more than 50 years. But when it comes to age less than 50 years, cornea opacity is 37.5%. So coming to cornea blindness, it is more common in developing country, and globally bilateral blinds are 4.9. And India, Africa has much percentage compared to other places. And again in cornea blindness, with time, trachoma has gone down, whereas undetermined cause of blindness have increased from 13% to 21%. In India, keratitis is a leading cause of ocular morbidity. Also we see keratomalacia, although there are programs for vitamin A supplementation, we see keratomalacia. Why are we worried about cornea blindness compared to cataract blindness? Because cornea blindness happens in young age and it affects high disability adjusted life years compared to cataract blindness. In Andhra Pradesh eye disease study, we found cataract, the mean age is 68.5 years, whereas cornea blindness, more than 50% are less than 40 years. So if you see the prevalence of cornea blindness in India, it is almost highest in many, total blindness is almost equal to China, and if you see prevalence percentage is highest 0.68, and cornea opacity, almost every places it is more compared to other countries. This picture I like to present in many of the iBanking forum is pride to have India, although we have more of a cornea blindness, but India is highly ready for to tackle this. Similarly, this also is a slide where it says India is almost sufficient for cornea transplantation. Coming back briefly to iBank, it's a not-for-profit organization which supplies cornea for sight restoring transplantation as well as for research and education. It has two components. One is administrative section, which deals with the public awareness and funding, And medical section actually has expanded beyond these four: harvesting, evaluation, preservation, and distribution, to prepare pre-cut tissue and DMEC rolls. Briefly about history, so Dr. Patton, who did cornea surgery, does cornea surgery, you must have heard Patton spatula. It started in 1944. Again, Pride of India is, after 1 year we started in India, although it did not go in that how it went in US, and a successful transplantation was done in 60. So there is a lot paradigm shift in eye banking. We have more focus on utilization compared to collection. From moist chamber, we have gone to intermediate cornea storage solution. It was initially thought to be charity model. Now it is self-sustainable model. And the function of eye bank has increased to, rather than storage, preservation, distribution, to pre-cut and DMEC roll. So this is a graph showing the increase in corneal transplants as well as the pre-cut in RIAB, which is the largest eye bank in India. So as models, there are independent eye bank, and most of the eye bank in India are associated with hospital, and majority are dependent on HCRP, and some are dependent on voluntary, but mostly HCRP. So what I want to describe here is hub and spoke model, which started with transportation industry. Why it started? Because to scarcity of resources and intensive demand for profit, hub and spoke model was started. Why they can manage with less resources. I always think that iBank is similar thing, because iBank is a hub and you can have HCRP or iDonate collection center as spoke. So the hub manages client relationship, quality, whereas spoke is a delivery model. It is in different parts of the country, and they just supply to hub. The benefits are two. One is increased efficiency, second is enhanced quality. So the iBank, where I started my journey, is Drishtidan iBank. It has, it acts as a hub, and other spokes are many district headquarter hospital, although in future we have a dream to go to 30 districts. And again in the distribution, from Bhubaneswar it goes to many places in the country. Previously it was planned that one iBank can be enough for 20 million people, and each iBank can be linked to 40 eye donation center. There's no need of more than one iBank in each city, and each iBank can have HCRP in 10 major hospitals. So basically we don't need more iBank. To have a high quality iBank, the resources can be pooled and one city will have one, and the expensive infrastructure can be used for evaluation, preservation, and all those high-tech pre-cuts and DMEC roll. And this increases the efficiency of standard. Otherwise, many iBank, there's just for namesake it is there, and finally it closed down because of the challenges. So when Drishtidan iBank started in 2002, recently we completed 20 years, the dream was to promote eye donation and to combat corneal blindness only in Odisha. However, it has gone beyond that. So you can see the collection pattern. To start with, in 4 years, it is 30. So all those who are in iBanking sector, they know what are the challenges initially. So after I finished my cornea fellowship in LB Prasad, I came back to Odisha. There was no iBank. So practically 3-4 years, I have not done any cornea transplant. So I joined with them in 2002. I went for their collection and past transplantation. And then in 2006, when LBP came to Bhubaneswar, it joined together, and you can see the growth. So 1,500 was maximum collection in 2018. Then as for COVID, it has gone down. So this is only thing is the voluntary portion is very less, but we have very high utilization because of the HCRP. So the only thing worse than being blind is having sight but no vision. So I'll come to my vision. What should be the vision for the country? I'll say no waiting list for cornea blindness in India. Although most of the surgeons, they say they don't have cornea blindness, but I feel there are cornea blinds where cornea surgeons are probably not there. And as law permits, maybe in future we can export cornea to other countries. And iBanking activities are more in some states, whereas zero in many states it is zero. It should start in full swing in all the places, and we need more training center and more training center for technician as well as counselor. Like Dr. Basak mentioned that we have enough cornea surgeon to do the transplant, but the problem is the follow-up. Many times patient don't come for follow-up. So we need a lot of general ophthalmologists who can treat the cornea transplant patient. And more lamellar surgery, as I understand, there will be always the penetrating keratoplasty will be more, because the most common indication for transplant is microbial keratitis. However, maybe more lamellar surgeons learn that, and more lamellar surgery, and we should work towards prevention of corneal blindness. For that, we need epidemiological information about corneal blindness in different parts of the country. Maybe there should be change in policy which help more cornea surgeons to do cornea transplantation, because many people don't get the certificate or the quota registration for the cornea transplantation. Thank you.
Thank you, Dr. Sujata, for a wonderful presentation, some very good inputs, some wonderful vision, and thanks